Okay, so specific endocrine glands and their hormones. So this is just a general thing, and then we'll talk about the hormones later on. So let's talk, we're going to start from the top and work our way down. The hypothalamus. Okay? The hypothalamus, there's neural functions, which hopefully you all learned about in A&P1, which I'm not going to spend time talking about. Okay? It controls heart rate, blood pressure, and so forth. All right? But endocrine system, there's a lot of functions also. This is where the nervous system and endocrine system kind of intertwine with each other. Okay? The hypothalamus is going to release releasing hormones and inhibiting hormones. If it has the word releasing in it, it's coming from the hypothalamus. If it has the word inhibiting, it's coming from the hypothalamus. These are the hormones, and 7 major ones there. These are the hormones that get synthesized, stored, and secreted by the hypothalamus. Now, all of these will target the anterior pituitary gland. Okay? Now, be careful with the words. This is where you got to pay attention to detail. Synthesize means to manufacture, to make. Stored, as kept as a reservoir. Secreted means released. Okay? They don't mean the same thing. The reason why I'm emphasizing this, there are 2 hormones that get made in the hypothalamus but are not released by the hypothalamus. They get, and they're not stored there. So there's 2 hormones. Let me repeat this. There's 7 hormones that get synthesized, stored, and secreted by the hypothalamus. There are also 2 other hormones that get synthesized by the hypothalamus but are not stored there and are not secreted from there. Those 2 hormones is something called ADH, or antidiuretic hormone, and oxytocin. These are stored and secreted from the posterior pituitary. The posterior pituitary does not make any hormones, but they're stored there and they are released from there, or secreted from there. Okay? Now, if we remove the posterior pituitary, okay, does that mean you're not going to make ADH or oxytocin? No, it's still going to make it. Now, here's a little side note too. If that posterior pituitary gets removed or destroyed, like as in a stroke, ADH and oxytocin, because it starts building up, it finds ways to get out into the bloodstream even though they don't have the posterior pituitary. Which is a good thing, because we'll need at least the ADH, okay? So just keep that in mind, okay? All right, so these are the hormones that get secreted, stored, and synthesized by the hypothalamus, okay? Again, you don't have to worry about the structure. Target tissue, in a nutshell, they all will go to the anterior pituitary. Okay? The functions, to tell you the truth, you could figure them out over there. It's pretty easy if you know the names of them. Thyroid releasing hormone is going to increase the thyroid stimulating hormone coming out of the anterior pituitary. Kind of like what I showed you with the hypothalamic pituitary target access. So that's not too bad. This is probably easy to memorize. Okay? And like I said, for all my exams, you can use the proper abbreviations. Some of them could get rambunctious, like here you have growth hormone inhibiting hormone. You know, so you call it GHIH. So some of them get a little rambunctious. So the three methods that the hypothalamus can release hormones. Okay? Here's the hypothalamus. It can either send blood hormones into the bloodstream and target the anterior pituitary, or they can make two specific hormones, ADH and oxytocin, and it could run down the stalk over here and get stored in the posterior pituitary. It doesn't involve the bloodstream. Or through preganglionic fibers. Oh, no, yes, autonomic nervous system. It could send it all the way down the spine and connect it to the adrenal medulla to release norepinephrine and epinephrine. So I'm not going to spend too much time on this because that was really about the autonomic nervous system, but understand that's where that comes in too. So the hypothalamus has three ways that it can actually have this hormonal control. And you can read these on your own or use these charts, but that's basically what each one is. Okay? And again, you saw this picture before, but the hypothalamus has three ways. 1, 2, 3 ways to control hormones to come out. And we kind of showed you that with the TSH going to thyroid and stuff. It's a very busy picture, but if you understand it, and one person actually asked me, how do you eat an elephant? I said, bite, bite, bite. Right? Don't worry about being overwhelmed by a big picture like this. Isolate each one. It'll make sense, and the big picture will make sense. Okay? All right, that's all I want to say about the hypothalamus. Now, the pineal gland or pineal body, very little for us to know. If you had it in A&P1, I'm just going to be going over the same stuff on there, just one slide. But basically, the pineal gland, also known as the pineal body, controls the circadian rhythm and the biological clock. Why you're living in Tokyo and now you fly over to New York City and your brain is still in 1 a.m. time from Tokyo, even though it's 1 p.m. time here in New York City, right? It's that kind of thing where your body has to adjust to that. Well, I bring this up because it does release a hormone called melanin, not melatonin, which is found where? Skin, right? All right. Melanin is a hormone that, or sorry, melatonin is a hormone. Sorry, melatonin is a hormone that comes out and it's going to control sleepiness. If there's a lot of melatonin comes out, you get sleepy. There's a lot more of it comes out in darkness, so it helps you to sleep. Okay. Now, I do know they sell melatonin over the counter as a sleeping aid for people. And I understand where they're coming up with this. The only thing is, just keep in mind that melatonin, we don't know the exact mechanism, but we know that it controls the onset of puberty. So if you're a parent that thinks that, well, I don't want to give my child a sleeping pill, but I can do this, it's pretty safe to give something over the counter, not everything is safe. Just be careful that if, I'm guessing that if you just give one melatonin to a child, that's not going to cause major problems as much as one cigarette is not going to cause lung cancer. But you do it on a routine basis, don't be surprised that your 7-year-old girl is going to have a period. Does that make sense? Because it can cause precocious puberty when you have a high dose of melatonin in their body. You don't know exactly the mechanism why that happens, but we know it has something to do with the onset of puberty with melatonin. Okay? So, trying to give back to the community, right? All right, that's all I want to say with that. Now, let's look at the pituitary gland, also known as the hypophysis. Let's look at the overview of this. Okay? The pituitary gland is also known as the master gland. I don't believe in that. I disbelieve it should not be called the master gland. Why would you agree with me that it shouldn't be called the master gland? would, think of the hypothalamic pituitary target axis. Why would I not consider the pituitary gland a master gland? Yeah, the hypothalamus is really, if you want to call it a master gland, that controls the anterior pituitary and a bunch of other things. That's really the master gland. But in some books, they consider that the master gland. I think because you got the pituitary gland that spreads out to all the other glands throughout the whole body, maybe that's why they do it. But you'll see it as referred to as the master gland in many different books. And again, it sits in that sella turcica, which is that bony structure in the sphenoid gland, or sphenoid bone. And I explained that as if there's a tumor there, it expands, it can cause a headache, right? All that stuff. So anyway, I put that up there because you will see it as a master gland. I had students explain, like, why is that a master gland? I agree with them. They shouldn't call it that, but that's what they do. All right, so the pituitary gland is actually two glands. Okay, we have the anterior pituitary gland, also referred to as the adenohypophysis. Remember how I said hypophysis is the same thing as the pituitary gland, but adeno, meaning glandular, is what this is. Now this is going to be the bigger portion. It's about 75% of the pituitary gland, and it's going to synthesize, store, and secrete 7 major hormones. And through embryology, the pituitary gland started off in something called Rathke's pouch, which is basically the mouth, and moves upward. Now I'll explain why that's significant in a moment, but that's how it forms. It goes from the up, or comes from below and moves upward. We also have the posterior pituitary gland that doesn't synthesize any hormones, but it does store and secrete 2 that came from the hypothalamus. This is known as the neural hypophysis because it came from the brain and moved downward. The 2 hormones that come from here is the ADH, antidiuretic hormone, and oxytocin that are made in the hypothalamus. But, let me get back to that. So we have the posterior pituitary coming from above, the anterior pituitary coming below, kind of fuses together, doing this. So that gray area is what's going to be our future posterior pituitary. Here's our future anterior pituitary. It comes up, fuses off, and that's what happens. That's why the pituitary gland is really 2 glands. And they work differently from each other. There's a wall there. The posterior pituitary is called a neural hypophysis because it comes from neural tissue. And if you do a histology view, you will actually, a histological view, microscope, you will see neurons in there. Okay? Clear about that? Here's a close-up of it. You don't have to worry about the names here. It's just showing you, here's the infundibulum, the stalk of the cherry. And that is directly connected to the posterior pituitary. Here's the anterior pituitary, which is bigger than that. It's about 75% anterior pituitary, about 25% posterior pituitary. But you can appreciate that this is really connected. The posterior pituitary is connected to the hypothalamus, which explains the ADH and oxytocin.
I have a question. If the posterior pituitary was compromised, can they remove just that, or do they have to remove all of it?
Yeah, they remove. There's going to be some anterior pituitary that they're going to remove also. Depends on, it also depends on the tumor, for whatever reason. Like if it's a tumor, it's going to spread this way, so they got to remove whatever they can of that. If it's a stroke, then they probably aren't going to do anything. They're just going to leave it there, and there's not going to be any problems with that. But they're going to try and salvage as much as the anterior pituitary as possible. Yeah. Okay? But don't worry about the parts here. Yeah.
If the oxytocin and ADH, you said it was originate from the hypothalamus and target the posterior, or are they?
I wouldn't say they target the posterior pituitary. They're going to target wherever their receptors are. There's not receptors here. The receptors are ADH. For that purpose, it's going to be the kidney. And for oxytocin, it's going to be the uterus and the breast.
Their origin is the hypothalamus.
The origin is, that's where, and you're looking at the chart, I guess, right? That's where you're going to have to put like a division there if you want, because like I said, you're going to have to modify it because the origin is the hypothalamus, but it's stored and secreted from the posterior pituitary. There are exceptions on it that you'll have to just adapt to that. Okay? Questions on that? Okay. So these are, in blue, these are the hormones that get released from the anterior pituitary. And here's the two we've been mentioning of the posterior pituitary, ADH and oxytocin. Okay? Now, let's talk about the anterior pituitary gland. All right? Histology. There's eosinophils, there's basophils, and there's chromophobes. Okay? Any questions on that? And that's what it looks like. Super? Any questions? Good. I'm not going to ask you questions on that. All right. We don't have good slides to actually show you on that, so I'm not going to. There's a lot of other stuff to be more concerned about. Okay? So don't worry about histology. I put it up there because once we get good slides, then I'll put that in there. But not good slides. Now let's talk about the anterior pituitary gland hormones. Now this is just an overview. And I'm going to be very brief with this because we're going to spend more time with this in the next few days. We have the thyroid stimulating hormone, TSH, and we kind of explained that. It's going to help, it's going to target the thyroid to secrete T3 and T4. We have growth hormone, that's GH, and that's going to stimulate most tissues throughout the whole body to grow. Whether it's the heart, it's the eye, it's everything. It goes to everywhere. Okay? We also have this crazy one, ACTH, adrenocorticotropic hormone, and this is going to stimulate the adrenal cortex, not the whole adrenal gland, but the adrenal cortex to secrete its hormones. More or less, it helps to secrete mostly cortisol, but it does the other ones minimally also, which we'll get into. We have FSH, follicle-stimulating hormones, and this is more the sexual hormones. This is going to, in females, it's going to make the egg sacs, called follicles, to grow. In males, it's going to help make sperm production. Okay? We also have another sister sexual hormone that comes from the anterior pituitary, and that's LH, luteinizing hormone. And what that does in females is that that's going to release progesterone from the ovaries, and hint, hint, whenever I say hint, hint, there's probably going to be a question about it someplace. It also triggers ovulation. So if a woman has problems getting pregnant, we want to also make sure they have an LH level. If it's very low, she's not ovulating. Ovulating, it means where the egg pops out of the ovary for a waiting sperm. All right? So if you don't ovulate, you're not going to have an egg that's going to be fertilized. So we check for LH levels. And in males, it also releases testosterone from the testicles. Prolactin is going to stimulate the breast to make milk. Now keep an eye on this. It's going to make milk. God bless you. It's not going to eject milk. It makes milk. We have another hormone that's going to eject milk. That's oxytocin. So make sure when you see the word milk, understand the verb that goes with it too. You've got to pay attention to details. And then you have this lesser significant hormone called melanocyte stimulating hormone, and this is going to make the melanocytes secrete more melanin, make it darker. We'll talk about that later too. So those are 7 major hormones from the anterior pituitary. Okay? The posterior pituitary gland. Okay? Histology-wise, it looks like that. Any questions? Good. All right. Won't ask you questions about that. All right. Just understand that there would be more neurons in there because it came from the brain and moved down, right? But I won't ask you questions about that. Now let's talk about the 2 hormones that are dealing with the posterior pituitary. Okay. We have something called antidiuretic hormone, ADH. This is also referred to as vasopressin. Okay? Let me show you what's going on here. And this is how you should wire your brain to understand things. We have ADH, which stands for antidiuretic hormone. Now, what does it mean when someone diureses? They pee, right? They're going to release a lot of water. Does that make sense? They're going to pee a lot. But this is an antidiuretic hormone. So does that mean, so if you have an antidiuretic hormone, what's going to happen to the amount of urine you're going to make? Antidiuretic. You're going to make less, right? If I'm going to diurese, I'm going to pee a lot. If I'm going to anti-diurese, I'm not going to pee a lot. So my urine volume is going to go down. Does that make sense? So the water is not going to go out. In fact, it doesn't go out, it gets reabsorbed and goes back into the bloodstream. So what happens to your blood volume if that should happen? It goes up. Right? If the blood volume goes up, you're putting more water molecules in the bloodstream. So if we have 12 people in this room, and each one of you is a water molecule, now we're going to put 100 people in this room. If you put more water molecules inside this room, more people, we're going to get closer and closer, and we're going to get tighter together. What's going to happen to our blood pressure? She'll remember. It's going to go up, right? So you increase blood volume, your blood pressure will go up. So increasing ADH is going to increase blood pressure. But in physiology, in A&P that we're doing, you need to understand the steps that we did to get there. As a doctor, as an RN, as a PA, physical therapist, sure, you know that ADH is going to do this, but that's because you already did this kind of schoolwork years ago. Well, this is your first time going through it. You need to understand this. Does it take longer? Sure. Don't find shortcuts, right? Do it step by step. Your brain will get wired and you'll be able to do this stuff easier and faster. Okay, does that make sense? All right. Now, that's what happens. But I'll give you a little tip too. ADH is also known as vasopressin. Same thing. ADH also does something else. It's going to vasoconstrict blood vessels. If we do this, what we're doing is, if your water molecules in the blood vessel, and now we're going to take the ceiling and floor and the walls and we're going to constrict and make it tighter. That's going to make our water molecules get closer together. What's that going to do to blood pressure? It's going to go up. See? Now, do keep in mind, we're going to learn a lot of ways that blood pressure goes up with hormones and stress and things like this that we're going to get into later on. So don't think that this is the only way that blood pressure goes up. But understanding this mechanism is going to help you later on with pharmacology, because there's a lot of medications out there. High blood pressure, hypertension is a very common condition that's out there. And there is a load of different medications out there. They don't all target the same thing, because each one of them will have side effects that patients don't want, and then they won't be compliant with taking their medication. So there's got to be other ways that we can do that. We have medications that will decrease this so that you can pee out. More about that when we get into diuretics and urology. Okay? So just to reiterate, decrease urine, increase blood volume will increase blood pressure. Okay? The other hormone that we have to be concerned about with posterior pituitary is oxytocin, and this one is going to target the uterus and give you wonderful contractions to push that baby out. It will also go to the breast to squeeze out milk or eject milk. Keep in mind, prolactin makes the milk, oxytocin ejects the milk. Okay?